So I may have had a heart attack a month ago. Not a scare or a close call, a bona fide heart attack. My left anterior descending artery was 98% blocked. Oh, and by the way, that's the one that they call the widowmaker. Yeah, and this smaller one here next to it, that one was blocked too. Statistically, I shouldn't really be here to describe what this actually felt like, but I am, so I'm gonna. And more importantly, why at 56 years old, it happened at all. And you might think you know because it sounds pretty self-explanatory, but you're probably wrong. So let's see. There's always this line that you don't notice until you've already crossed it, right? And I think that's why they say that hindsight is 20/20. One day your life is ordinary, the next it's divided into before and after. And I didn't know that that line was going to be drawn for me on October 2nd of 2025. I was editing late at night, which isn't unusual for me. 1 to 4 a.m. is actually my most productive time. It's quiet, I get in the zone, the world just kind of disappears. But that night, this strange ache right in the center of my chest, beneath my sternum, just would not go away. And sternum is breastbone. It was this pressure that just made me keep stretching my shoulders every few minutes. You've all had those muscle aches where you're typing at a computer for too long maybe, and you're like, you just feel like you need to stretch. So that's kind of what I chalked it up to. I had been typing at my computer for hours at that point, which again was not unusual for me. And I get that pain all the time. At this point, it's about 2:30 in the morning. I forced myself to shut my computer and go to bed, but I was still having this chest pain and assuming I just needed a good night's sleep and it would be gone in the morning. It wasn't. My alarm went off at 6:45, as always. I woke up a little groggy, and then in a split second, every sensation crystallized into this very sharp focus. That dull ache from a few hours earlier was now this intense burning spreading outward from the center of my chest, radiating up to my jaw and through to my back. Like someone had their foot pressed behind my left shoulder blade. It wasn't coming and going. It was constant and heavy, almost alive. It's the only way I can describe it. It had this life of its own. Both of my arms felt weak and super heavy, like they were filled with lead, and I was also incredibly sweaty, looking like I had just gotten out of the shower, pouring sweat. And that's actually what told me that there was no question what was happening. It was textbook. The first thought that hit me was,
I'm having a heart attack.
The second one was, I need to let Coco out and feed her before the ambulance gets here. So I did. While actively having a heart attack, I made my way downstairs and I fed my dog. And then I flopped on the couch and called 911. And hearing those words come out of my mouth, I'm having a heart attack. And you know, it's hard to describe. You hear it all the time on TV shows. You know, as a nurse, I've heard it probably a million times, but never out of my own mouth. And it took the ambulance probably about 20 minutes to arrive, which doesn't sound long until you're having chest pain. Meanwhile, my pit bull, my lovable, slightly neurotic pit bull, is running loose in my house. And all I could think about was, this is gonna be super interesting, because in a few minutes, several strangers are gonna bust through my door like the Kool-Aid man, and I don't know how that's gonna go. Well, I don't know when I'm gonna be coming back here, so I didn't want to crater in the event that, you know, I didn't make it back. You know, that thought briefly crossed my mind. And then, you know, there came the knocks at the door. Ma'am, is your dog friendly? Normally, yes. In this scenario, I don't know. She knows something's up, but I didn't have the energy to really deal with anything at that point. I didn't have the energy to be her emotional support human. So they were just gonna need to figure it out. And then The next thing I knew, I had 2 cops and 3 EMTs standing in front of me with very concerned looks on their faces. From that point on, time started doing something really weird. It was like somebody was pulsing it through a Cuisinart. It's the only way I can explain it. Speeding up and slowing down simultaneously. You know, I was wheeled up to the ambulance, and it's just all a blur, as people usually describe it is, right? There's nitroglycerin being shoved in my mouth, baby aspirin, EKG leads going on, blood pressure cuffs tightening, me saying, oh my God, I'm inside an ambulance because I think I'm having a heart attack. And then, you know, somewhere in there, I said, what are you seeing on the monitor? I was trying to turn around and look at it, and also asking what my blood pressure was. And one of the EMTs tilted his head and said, do you work in healthcare? All I could manage was,
Yeah.
and he said, well, you've got some ST depression, definitely something going on, and your last blood pressure was 174/98. By the time I got to the ER, I already knew what was happening. I was having something called an NSTEMI, or a non-ST elevated myocardial infarction. In plain English, a heart attack, but not the kind that you see in medical dramas with alarms and crash carts flying all over the place. That kind is typically a STEMI, or an ST elevated myocardial infarction. And basically, this means that one of the major coronary arteries is critically or completely blocked, and the heart muscle is actively dying. It's the classic time is muscle emergency, not always a code scene, but always a cath lab as soon as possible scene. In contrast, what I was having was a non-STEMI, which is quieter, but still dangerous. There's still some blood getting through, but not enough to sustain the heart muscle. And the EKG might just show subtle changes, ST depressions, T-wave inversions, or sometimes nothing obvious at all. Diagnosis usually comes from the lab work that's done later, specifically troponin levels that climb higher with each blood draw. And troponins are cardiac-specific proteins. They live inside heart muscle cells and only show up in the bloodstream when those cells are injured and they leak into circulation. So even a small elevation means there's been some degree of damage. Something's gone on. My first draw came back as 500, enough to confirm that something was very wrong. But over the next couple of days, it kept climbing, eventually peaking around 22,000 by day 3. Yeah, so each number was like a quiet reminder that my heart had been through some. I also knew that I probably had a cardiac cath in my future. Little did I know that I actually had 2 of them. So the first one was diagnostic, meaning they weren't placing stents, just really mapping the arteries and figuring out where the blockage was and how bad they were. And they went in through my radial artery. I don't know if you could see, I still have the mark there. They gave me Versed and morphine, which is pretty standard conscious sedation, enough to blur the edges, but not knock you out, except it didn't really work on me. No, yeah, it didn't touch me. I mean, I drifted in and out, but was apparently quite talkative, but we'll come back to that in a little bit. Now, after the procedure, my doctor came in and told me my LAD, the left anterior descending artery, was about 98% blocked, as was a smaller branch coming off of it, so I would need a stent, which he would place later that evening at a different hospital that was better equipped for more complex cases. But I mean, at least at that point, now I knew exactly what I was dealing with. Now, in the holding area before the second catheterization, my cardiologist, Dr. O'Keefe, mentioned casually, by the way, I see you're on LDN, which is low dose naltrexone, which I didn't account for that first time. So you were pretty alert through the first cath. You know, he just said, you know, I always just want to make sure that we get you sufficiently sedated for this one, since it's going to be a bit longer and more involved. You know, I explained that I take LDN for peripheral neuropathy, but in really minute amounts, like basically microdosing. It's barely therapeutic. And he nodded and said, well, you know, that makes sense, but it doesn't matter what amount you're taking it. If it's in your system, it'll block sedation from opioids. Not true either. It depends. I mean, certain opioids, yes. Fentanyl, no. And that's what they gave me the second time. But we'll get there in a second. You know, that was the plan at least. Get me better sedated during the second cath. They're prepping me again, and you know, this time for the femoral approach, which is this major artery down here. Monitors, oxygen, drapes, and then they push the IV Versed and fentanyl. And like I said, same as before, it barely touched me. I felt it go in, and I got kind of warm and flushed and felt a little something, I guess. But I don't think I even closed my eyes once.
Which is...
Lately, I've been talking a lot about anesthesia and anesthesia awareness. So I found it so ironic that I was experiencing it, even though it was conscious sedation, it wasn't general anesthesia. I was not sedated to the point where I was comfortable. And the femoral artery is a really deep, high-pressure vessel in your groin. So in a femoral cath, the cardiologist inserts what's called a large bore introducer sheath, which is a short plastic tube that serves as the entry point into the artery. And then a guide wire is threaded through that sheath and advanced only a very short distance before it slips into the external and common iliac arteries, and then eventually into the abdominal aorta. And then from there, it travels upward through the thoracic aorta, looping into the ascending aorta, which leads directly down to the coronary artery openings, the left and right coronary ostia, which are these little guys here. And they sit in the aortic root, just above the aortic valve, within the sinuses of Valsalva. The catheter follows that same route over the guide wire like a rail system until the tip is precisely positioned at the mouth of the left coronary artery, where it can access the left anterior descending or the circumflex artery and the smaller branches. So that's what makes this a left heart catheterization, because they're working inside the arterial system and the coronary vessels feeding the left side of the heart. The catheter itself is tiny, maybe 2 or 3 millimeters. Honestly, it's adorable. It's precious. But then suddenly it's injecting contrast and taking x-ray selfies and inflating balloons, dropping stents, ordering DoorDash for all I know. It's like the Swiss Army knife of interventional cardiology. So I had one stent placed in my LAD artery, and a smaller branch coming off of it was ballooned, which means a tiny balloon was inflated right where the narrowing was, pushing that plaque back against the arterial wall to restore blood flow. And then sometimes this balloon will be drug-coated to prevent re-narrowing. It's basically medication-delivered angioplasty. So, 2 arteries, 2 blockages, 1 stent, 1 balloon. Fully conscious while they played cardiology Mario Kart with my coronary arteries. Now, when the cath was finished, normally all the wires and catheters are removed. But if you've been heparinized to prevent clotting during the procedure, and most of the time most people are, they need to leave that sheath in. Remember the sheath we talked about earlier that introduces the catheter up into the artery? Now, why does this matter?
I haven't the foggiest.
Because I had that sheath still in, I couldn't move my leg at all.
Even the tiniest bit.
So why is that a big deal? You think, yeah, maybe a couple of hours, okay. You've got some fentanyl on board, they'll probably give more pain medication. That would have been fine if that was the case, but for me, it was about 8 hours before my prothrombin time normalized enough for them to remove that sheath. But the whole time, you know, I was basically told, do not move. Don't move your leg, don't bend your knee.
What?
Nothing. And I don't have back problems normally, but try laying flat for that length of time and tell me that your back isn't going to be absolutely screaming. Even a few hours of that to me was the most traumatic part of everything that happened. Now, when it was finally okay to remove the sheath, that same cath lab tech who'd been in the procedure with me came back to pull it. And here's the thing. Prior to the early 2000s, they used to apply sandbags for pressure afterwards. They don't do that anymore. Now, it's done manually. So what does that mean exactly? What does that entail? Well, he explained, I'll take my fingertips and push them down on the puncture site, focusing all 180 pounds of my body weight on that one point for 30 minutes until I'm satisfied that you've clotted and the artery has sealed. Okay. So there I was at 1:30 in the morning with Jamal's fingertips pressing hard into my groin, my right groin. And both of us trying to make small talk and pass the time, just to keep my mind off the pain and, you know, to kill some of the awkwardness. We're talking about sports, food, whatever keeps it from being super awkward while my artery is being held closed by him. Okay, for the record, the most common question you'll get asked after a heart attack by literally everyone is, you having any chest pain? Nurses, aides, residents, phlebotomists, the transport guy. I think even the woman delivering my lunch tray. It's like the unofficial hospital greeting if you're in a cardiac unit. Having any chest pain? After a while, I wished I had a t-shirt that I could just wear and point. Still no chest pain. No chest pain. I was also connected to a really bulky heart monitor, wires and leads everywhere, and had this giant bandage over my right groin with the pressure dressing underneath it. And every time I shifted, it felt like one continuous bikini wax. Tegaderm, if you ever wanted to branch into the beauty industry, you're halfway there. Just market your dressing as an at-home wax kit and you'll be golden. So basically, I stayed in bed. I was relegated to bed all day. No stairs, no bathroom, just monitors, meds, and a lot of any chest pain. So it didn't really give me a great idea of what walking down the hall would even feel like. At that point, it's day 3, and I had not literally been out of bed. So everybody asking me if I was having any chest pain was kind of strange to me because I'm like, no, sitting here in bed, I'm fine, but I don't know what's gonna happen when I go and try and stand up. So on the day of discharge, I stood up finally, and those first few steps were honestly terrifying for me. My heart was racing, I felt short of breath, and that same familiar chest pressure started creeping back in. I told myself it was normal, post-procedure soreness, anxiety, whatever. I was also just allowed to walk off the cardiac step-down unit with my daughter and out to her car. So this is what's so odd to me. Back in the day, when I worked in ICU, CCU, granted, we're talking 20 years ago, if you were in the hospital and you were a patient, you were not allowed to just walk out. If you were discharged, you either had to be wheeled in a wheelchair down to the front door until this like imaginary line. And then as soon as you hit that line, whether it was with a nurse or transport, you were in that wheelchair. And when you hit that line, they were like, okay, see ya. You were allowed to get up and walk. But up until that point, you had to be wheeled down. So it was very odd to me that for an entire 3.5 days, every eye blink, burp, hiccup, anything I did was monitored. But as soon as they discharged me, it was like, go with God. May the force be with you, sayonara. And my daughter and I are just like, do we just leave? And yeah, I just kind of walked out. I'm at the elevator. I'm like, this is really strange because now I'm having chest pain and shortness of breath and nobody seems to give a shit. By the time I got down to her car, you know, sitting in the front seat, I'm like, I'm not feeling well. Like I'm having chest pain. It feels like it did when I called 911. Like that's how uncomfortable I was. And you know, my daughter's a PA and she's side-eyeing me like, are you serious? Like, are we going back in? Like, what are you telling me? It was just a weird experience. I don't know if I'm making more of it than I should be, but it was kind of weird. I also went home with a small pharmacy of meds. Yeah, these are all of my cardiac meds. I'm now on atorvastatin, carvedilol, valsartan, aspirin, ticagrelor, Zetia, Repatha. These are all cardiac cornerstones, and they're meant to lower cholesterol, thin the blood, reduce heart strain, and keep everything calm. But they also made me feel like a zombie. It's really strange going from, you know, a high adrenaline, acute crisis mode type situation to the sluggish quiet of recovery. At my cardiology follow-up, he walked in and said, you know, we've started you on a pretty strong statin, but my suspicion is it's not going to bring your LDL down because I think you have familial hypercholesterolemia. FH is a genetic disorder where your body can't clear cholesterol from the blood efficiently. But how does cholesterol get removed normally? So we all have LDL receptors on our liver cells, little catcher mitts that grab LDL cholesterol out of the bloodstream and transport it into the liver for clearing or repurposing. Once inside, the LDL particles are broken down and either removed or used to make things like cell membranes, hormones, and then after it makes this trip back and forth, this little receptor gets recycled back out to the cell surface to play cholesterol catch all over again. In people without FH, this is a smooth, efficient cycle. But with FH, a protein called PCSK9 becomes overactive. Normally, its job is to periodically tell the liver, okay, you've used that receptor enough, now destroy it. In FH, that message goes into overdrive. So instead of these receptors being used a few times, the hyperactive PCSK9 messaging causes their destruction on a greater scale in a shorter amount of time. So fewer receptors mean more LDL left floating around in the bloodstream, silently building plaque, possibly even from birth. So that's why FH is often called a silent time bomb.
Is that true?
True enough.
And here's the ironic part. Back in 2015, I was hired by Amgen Pharmaceuticals as part of the nursing team that helped launch the first PCSK9 inhibitor ever approved for use, which is called Repatha. I saw people who had walked around for most of their lives with alarmingly high LDL levels all of a sudden have them drop significantly. I mean, we're talking sometimes 50 to 60% within 2 weeks of their first dose. Very effective drug. I just never imagined that I would need it. So it's kind of a full circle moment. And, you know, after explaining this to Dr. G, he looked at me and he said, well, you know, your kids should probably get tested too. But what does that entail exactly? How do you test for genetically mediated high cholesterol? Initially, doctors will piece it together a few different ways. Usually, if they have super high LDL levels coupled with a family history, and then specific labs like ApoB and lipoprotein A can help paint a picture, but they don't quite prove it yet. The only way to confirm FH is through genetic testing looking for mutations in one of three genes: LDLR, ApoB, or PCSK9. And there are two major types of familial hypercholesterolemia. There's heterozygous or HeFH, and then there's homozygous or HoFH. With heterozygous FH, you inherit the gene mutation from one parent. It's far more common, affecting about 1 in 250 people. And LDL levels typically run between like 190 and 400 milligrams per deciliter if untreated. That's what you'll typically see. And heart disease often appears in adulthood, but earlier than normal. Now, with homozygous FH, on the other hand, this means that you inherit mutations from both parents. It is extremely rare, about 1 in 250,000 to 1 million people, and obviously much more severe. LDL levels can soar way above 500 milligrams per deciliter, and heart disease can develop in childhood or teens without aggressive treatment. So that's why identifying it early really matters, because in both forms, it's not about lifestyle. It's literally written into your DNA. And so far, my son's been tested and it came back with elevated ApoB and lipoprotein A. Since FH is inherited, if one parent carries the mutation, each child has a 50% chance of having it too. And this is why familial or cascade screening is incredibly important. It can literally save lives before symptoms ever appear. So the lab results that wouldn't budge were kind of just chalked up to my diabetes. But even then, my lipid profile looked a lot worse than it should have. So no, I don't look at this as being bad luck, and it wasn't stress or diet related. It was genetics, and knowing that changes everything, not just for me, but for my family. Because once you understand the why, you can do something about the what next. So if your numbers have never quite made sense, you might want to ask your doctor about FH. Like, don't wait for a heart attack to force that conversation. And if you're dealing with FH or neuropathy and you feel like you need a little more support, you can always book a call with me over at lucidmedhub.com. Recently, I shared another story that I had also kept to myself for years. One that's shaped just as much of my life as this has. So, since I seem to be in a sharing spirit, watch this next, and please stay healthy and lucid.